We'll go ahead and start grand rounds this morning, or this afternoon. Good afternoon. I'm James Morris. I'm the Program Director for the GI Fellowship and Associate Professor of Medicine here at the medical school. And today's topic is a new paradigm for H. pylori. And I'm going to do a bit of disclosure here. So I have no conflicts of interest with regard to this presentation. I will tell you that every drug that I will discuss today in some form is off-label for the treatment of H. pylori. So in terms of disclosure, you find that every treatment that we will discuss has evidence behind it but may not be approved by the FDA. So our objectives today, so the learner will acquire knowledge and skills to evaluate patients who are potentially at risk for H. pylori, develops treatment strategies for H. pylori eradication, including resistant organisms, and also gain an appreciation of the development of the idea of H. pylori as a pathogen. So with that, we're reminder that H. pylori is one of the most common bacterial infections affecting humans. And it is an important cause of peptic ulcer disease, and also for those individuals who are infected with H. pylori, the World Health Organization has classified this as a class 1 carcinogen for the development of gastric cancer. H. pylori may have a role in functional dyspepsia, and we find that patients who are treated for H. pylori who have dyspeptic symptoms do better later on with regard to abdominal pain. There is some increased risk of ulcer development if you are taking aspirin or NSAIDs, and we have potentially identified it as an unexplained iron deficiency source in some patients. We also have an association with idiopathic thrombocytopenic purpura. And the reason I chose this topic is there's been a change in the course of the literature in the last 2 years with regard to the testing and treatment of H. pylori. Dr. Todd talked to us a few years ago about H. pylori, but I felt there was enough of a difference in the way that we're going to discuss H. pylori that we should readdress this topic. So if we look at this organism, this is a gram-negative rod that has a spiral shape to it, and you see that it has flagella. Those flagella are very important for the pathobiology of this organism because it allows it to move rather rapidly to acquire an environment that it likes better. So if you look at those individuals who are at risk for H. pylori, we find that most individuals acquire the infection before childhood, that is, before 2 years of age. And the reason that you don't remember getting infected with H. pylori is because you were probably a cranky child when you got the H. pylori, had a little dyspepsia, and got over that dyspepsia over a few days. We see that there is a particular odds ratio risk of getting H. pylori because of if your mother was infected with H. pylori, you're at risk for getting H. pylori. And part of that is because you have such close contact with your mother in the very beginning of your life. There may be sharing saliva, your mother kisses on you, cleans you up and so forth. And so there's a significant risk of a child being infected with H. pylori. Also, if your siblings are infected, you have an increased risk of being infected with H. pylori. And there is a somewhat increased ratio of being male and having infection with H. pylori. Other risk factors that we have identified is birth outside of North America. And North America, referring to Canada and the United States, has a higher risk of infection with H. pylori. H. pylori is probably lowest in North America when we look at the entire world's population. Some of this may be related to a water supply issue that we see. There is also a birth cohort effect that I'm going to tell you about in just a minute and explain. And we see that there's higher incidence in those in certain racial and ethnic groups and those who are in socially disadvantaged environments. So what am I talking about here in the birth cohort effect? We see that seroprevalence, those individuals who are born before 1920 have a 73% incidence or prevalence of having H. pylori, and those born after 1980 have a 22% chance of having H. pylori. A few years ago, one of the ways that you could remember what's your chance of having H. pylori is the age of the patient would equal, in a general sense, the prevalence of that individual of having H. pylori. So if you were 58 years of age, you would have about a 58% chance of having H. pylori. And we see that this prevalence has dropped significantly in the VA population, which has both targeted H. pylori for eradication and also as we have become more industrialized, in development of antibiotics and sanitation, we have seen a drop in the prevalence of H. pylori. We know that there are pathology studies from France where they went back and looked at the autopsy data and found that the development of gastric ulcers and duodenal ulcers developed around the late 1870s to 1880s and gradually or increased over that period of time and then began to regress in the early 1900s. And that's because two things happened. We became more of an urbanized population in the late 1800s, and then as we gained sanitation, refrigeration, and got a sanitary water supply, that led to less chance of transmittance of the H. pylori. So we've seen a drop in H. pylori. And basically all cultures are infected with H. pylori. You can also look at the genetics of H. pylori and find that you can see a migration from central Middle East, Africa, and it is spread throughout the rest of the world. And you can map where somebody is from based on their H. pylori genetics. So let's get into the weeds of the pathophysiology for just a bit. So there is gene expression of this organism that is depending upon the pH that is different in in vitro environment versus the gastric mucosa. It expresses different genes in different environments. We see that in a low pH environment, it will develop motility genes which allow the flagella to move this organism along, and urease, which creates a protective buffer around the organism. So it likes to live in an environment of pH of 7.2, but also can live in that pH of 3, but it prefers to live in more neutral environment. And if it finds that it's in an environment that is very hostile to it, that it will migrate rapidly to a more favorable location below a mucus layer or a mucus layer so that it is protected from destruction. One of the things that it also is allow it to be an infective organism that causes problems is that the Helicobacter can bind to Lewis antigens, and that allows the bacteria to bind to the antigen. It can also bind to class 2 major histocompatibility complex. It also likes to bind to toll-like receptor 4s. And once it's bound to the host cells, then it can potentially cause damage. There are periods of the bacterial DNA that have what are known as CAG pathogenicity islands, and it creates a potential secretion apparatus, which then results in a subsequent gastritis in the host. And it also has causes expression of interleukin-8 by the host from this CAG gene, possibly resulting in the development of an ulcer. You can also see VAC-A expression resulting in gastroduodenal disease. And likewise, from the host, you get a polymorphisms in interleukin-1 beta, and when this polymorphism is seen, this is an individual who is more at risk for hypochondria, and then subsequently is at risk for gastric cancer. As you develop interleukin-1, this inhibits your gastric acid secretion to allow this host or this organism to do its damage. What we see is that the bacteria will cause tight junction disruptions. It produces cytokines, proliferation, and leads to the apoptosis of the cell. And inside the cell, what you see is nuclear factor kappa B and activator protein 1 that can then lead to these pro-inflammatory cytokines and cellular adhesion molecules to be activated. What happens in CAG-A is it is tyrosine phosphorylated by the host SRC kinases, and then that regulates the cell morphology. So other things that you can see, and this bacteria does lots of things for its pathogenicity, and I'll demonstrate this in an illustration just a minute, and it'll make more sense. So H. pylori results in this decrease in somatostatin and duodenal bicarbonate secretion, thus reducing the acid neutralizing effect of the duodenum. Its acid secretion effects can be complex, and it can reduce acid secretion. It can also increase acid secretion. It results in T cell activation by the HP infection, and this can lead to even more inflammation and gastroduodenal disease. And then there are T cells that develop cell line growth due to the VAC-A gene expression by the bacteria. So to put it all together, here you see a diagram of an individual who has been infected with H. pylori. The H. pylori has multiple adhesions with the Lewis antigen. You see the nuclear factor kappa B leading to interleukin 8 in recruitment of polymorphonuclear recruitment. You see CAG-A, which gets phosphorylated, which causes actin polymerization here, which then encodes the potential for binding and injury to the cell. VAC-A is shown here, which disrupts these tight junctions, which then leads to apoptosis of the cell, leading to the ulcer that we see clinically. And then you see the various host responses with production of tumor necrosis factor, interleukin 1B, that result in mucus glycoprotein changes and bicarbonate secretion changes. And in an environment where this acid is expressed here, you see that the bacteria gets upset and then decides it's going to move on to a different area in the host. So one of the things that we see with H. pylori is this graphical diagram of the different ways that an organism would affect a host. Here you see the normal gastric mucosa here on the left, and this individual with a higher level of acid production at the top of the screen versus a lower level of acid production at the bottom of the screen, and extending from childhood to an elderly person. So if an individual gets infected, you can have an acute H. pylori infection with pyrosis, dyspepsia, belching, which was the first thing that was reported in the original papers reporting H. pylori infection. It thus leads to a chronic H. pylori infection, and then you can go of multiple different pathways. If you go the antral-dominant pathway, then you can lead to a duodenal ulcer, or you may lead to an asymptomatic H. pylori infection. In those who are non-atrophic, it can lead to a pan-gastritis, and then subsequently to an asymptomatic H. pylori infection. And some of these individuals will move on over to a malt lymphoma along this pathway. Those that have more of a body or corpus predominant gastritis can develop a gastric ulcer. But a fair minority of these patients will develop intestinal metaplasia, which, if left to its own guise, the H. pylori can then lead to dysplasia and development of gastric cancer. So here you see a nice cartoon version of the pathways at which H. pylori can take to cause various degrees of disease and flavors of disease. So who should I test for H. pylori? Who should I approach and consider for testing? Well, in 2007, the ACG guidelines from the American College of Gastroenterology indicated these were the 4 groups of patients who should have testing for H. pylori. Those who have active peptic ulcer disease, either gastric or duodenal. Those with a confirmed history of peptic ulcer disease who had previously not been treated for H. pylori. Those individuals should be tested. Individuals who had a gastric or malt lymphoma that was considered low grade, because those who have a very low stage of the malt lymphoma could theoretically be treated only with eradication of the H. pylori. And we know that if you have an early gastric cancer and you have an endoscopic resection, that those individuals benefit from H. pylori eradication if the H. pylori is there. However, in 2017, a new set of guidelines from the American College of Gastroenterology were published, and they greatly expanded those individuals who should be considered for treatment, for testing. And these are listed here. So peptic ulcer disease and gastric mucosa-associated lymphoid tissue remain on the list. The early gastric cancer remains on the list. But what you see is that those individuals who may have dyspepsia that is uninvestigated may benefit from H. pylori testing. Those with functional dyspepsia, individuals who have GERD and may have atypical symptoms, that may actually be a sign of H. pylori. Individuals who are going on low-dose aspirin usage have a benefit of H. pylori testing and treatment because of the potential for ulcer development due to the concomitant H. pylori and aspirin usage causing ulcer development. Individuals who have an unexplained or iron deficiency anemia that cannot be found may also benefit from H. pylori testing, and if present, may benefit from treatment. And then there is an association of idiopathic thrombocytopenic purpura patients, or ITP patients, are those individuals who have been shown that if you treat H. pylori, have an improvement in their platelet counts. And then those individuals who are asymptomatic but have a family history of gastric cancer. Those are individuals who would benefit from testing. And then there are others that have been reported as case reports. There is no definitive recommendation for screening, but there have been case reports of individuals with lymphocytic gastritis. Of course, this is seen when you take a biopsy at an EGD, and so most of the pathologists would check for that. Individuals with hyperplastic gastric polyps have an increased risk potentially. There's been a report of a few patients with hyperammonemia, and then those with hepatic encephalopathy and cirrhosis, and then hyperemesis gravidarum may be also an indication. There is no definitive data for H. pylori testing in these patients, but as I said, there are a few case reports here. So how should I test for H. pylori? And this is the area where there has been some shift in the way of consideration for testing. We'll start with the non-endoscopic testing. So there are 3 ways that you can test for H. pylori here. One of which is serology. It's inexpensive. It has a fairly good negative predictive value. It's widely available. Unfortunately, if you have a low H. pylori burden, it's a poor predictive, predictive value, and thus may not be useful in those situations. And if you have an individual who is treated, then that individual, it's difficult to determine whether or not they have H. pylori after treatment because their serology will remain positive throughout their lifetime potentially, and thus you are unsure if you have a truly active infection once you've treated somebody for H. pylori. And thus, because of this, serology is generally not recommended for a treatment method for H. pylori. Other ways that you can test are urea breath test. Urea breath test tells you if you have an active infection. It's not affected by the H. pylori prevalence, and it's useful before and after you have treated a patient for H. pylori. The disadvantages is there's some accuracy inconsistencies. If you have PPI usage, then that can result in accuracy, particularly if you are on, have not held the PPI. So generally recommended to hold the PPI for 2 to 4 weeks before you do urea breath testing. And there is a small radiation dose with urea breath testing because you are using a radio-labeled agent. Not available at this institution, but is available in town in the Willis-Knighton system. They do have the capability of doing this testing. The other test that can be used is stool antigen testing. Again, identifies somebody with an active infection. Its accuracy is not affected by the H. pylori prevalence. It's useful before and after treatment. There's fewer data available about the polyclonal test. And again, its accuracy is affected by PPI and antibiotic usage, both of which should be finished and or held for approximately 2 to 4 weeks before you test an individual for the presence of the H. pylori, because you can get false negatives in this case. So this is the non-endoscopic reasons why you have testing for H. pylori. And the reason I present this is because not every patient should go for an EGD for H. pylori testing with biopsy. That's not a good use of resources. So we do have a test available that you can use non-endoscopically to evaluate somebody for H. pylori that you can use in the primary care setting. For those who are looking for what are the invasive tests for H. pylori, I have those listed here. So histology is available. It has excellent sensitivity and specificity. You can use special stains or silver stains or Giemsa stains to look for the bacteria. And it also provides you gastric mucosa, so you can look for intestinal metaplasia, gastritis, or other findings on the pathologic specimen. The disadvantage, again, is it's very expensive from a usage standpoint in that you both have an endoscopic evaluation and a pathologic investigation that occurs, and so you have those bills generated from that. There is some inter-observer variability in the reading of the pathologic specimens, and accuracy can be affected by PPI and antibiotic usage. Again, one of the things that we do to overcome this is we take multiple biopsies and we try and target the intersura of the stomach, as this is a site where H. pylori likes to migrate to, and is one of the last vestiges that you can pick up H. pylori in a low in a situation where there is low numbers of H. pylori. There's also the rapid urease test. It provides a rapid result within an hour or 24 hours, depending upon the test. It's, again, not as accurate as patients on PPI. It does require an endoscopy. It does not add pathologic cost. The disadvantage is it's less accurate after treatment or patients using PPIs, and it does require endoscopy. And for the most part, it has faded in the last 2 to 3 years as hospitals are asking us to remove this from usage as a test for H. pylori because of reimbursement issues and also because of these accuracy issues that have recently been identified. Another way of identifying the H. pylori is culture. This can be a bit challenging, not from the standpoint of collecting the specimen, but from the logistics standpoint of testing for H. pylori. It has specificity of 100%, and it allows antibiotic sensitivity testing. The problem is the logistics is really in town right now. The only people doing this testing is Mayo Clinic, and you have to get it on the FedEx plane that day, or it does not get run by the testing site. So these patients have to be done in the morning so that the specimen can be packaged and sent to the airport so it can be sent to testing purposes. Disadvantages is its difficult culture protocol. We'll discuss that in just a minute. And it's not widely available. Again, our access to it is to go to Mayo, and it is expensive. It does add cost to the patient. The advantage is it does provide some resistance data for you. It's also recently been more marketed as a PCR analysis that looks at sensitivity and specificity is excellent, permits antibiotic resistance detection, although it's not widely available and the technique is not standardized. So here is the representation of the urea breath test. When you're looking at this testing, for an individual, they ingest 13 labeled carbon urea. It's then broken down by the urease from the urea to ammonia, and then you have 13 labeled carbon dioxide, which the patient then breathes out. And so you see in a graph, in this case in a patient with a negative breath test, they will not have this expiration of the 13 labeled carbon. With a positive urea breath test, you see that there is production of 13 labeled CO2, thus indicating a positive test in active infection. So how should I test for H. pylori? Really, these are our three mainstays for testing for H. pylori. It's really the urea breath test, the stool antigen, and gastric biopsy. And if we need to, we as gastroenterologists can do the additional PCR analysis and or send the specimen for culture. So if we look at treatment for H. pylori, there is an effectiveness to the therapy. And what we see is that in individuals who were not eradicated for H. pylori, we see that there is a recurrence of greater than 80% in these individuals. And those who are eradicated the H. pylori, the recurrence of ulcer and gastritis is significantly lower. So I want to take a break here and just give you a little bit of the history of how H. pylori began as a potential pathogen. And if you have not reviewed this material or looked at this material or heard the story here, it is a fascinating tale. And the reason I'm using the term ulcer tale is that this is a story that began in 1981. And there began in Perth, Australia with Barry Marshall, who was a resident or registrar in the British system who needed a project for research. And so he was sent by one of the gastroenterologists down to the basement of the Royal Perth Hospital to find the pathologist down there who had a potential project because he had discovered curved bacteria in some gastric biopsy specimens. And like any resident, he was spending 14 hours a day. He had 4 children. He was very busy, but he took on the project, and he and the pathologist, Robin Marshall, developed this project over cigars and coffee. And so they decided to look for individuals who may have this unknown bacteria and who would have it. So they devised a system of trying to culture the bacteria. And so they would obtain gastric biopsy specimens and send those on for culture to see if they could find this bug. And they were very unsuccessful until an MRSA breakout occurred in the hospital. And because of this MRSA breakout, they received multiple additional culture specimens for analysis in the bacteriology lab. And over Easter holiday, they ran out of time to review the cultures. And so the cultures for H. pylori were left behind and were not read. And lo and behold, when they came back from Easter holiday, there were little white specks indicating bacterial colonies. Then investigated those and found a gram-negative bacteria, which was very similar to what they were finding on the gastric biopsy specimen. And so thus they had identified potentially an unknown bacteria here, or isolated the bacteria. Unknown to Barry Marshall before this time, at 48 hours, all of his culture specimens had been thrown away as per routine in the hospital. So it was a fluke that on Easter weekend that these specimens got left behind, and that's what led to this potential discovery of the colonies of bacteria. From that, they decided to create a observational study, and so Barry Marshall interviewed every patient going for an endoscopy. So he interviewed all of the inpatients, he interviewed all of the outpatients, and they devised a study with 100 patients in the study. Why 100 patients? 100 patients were chosen for the study because that was before really wide usage of computer, and it would make the numbers easy to calculate. And so they completed the study by looking at 100 patients who underwent an EGD, and then Barry Marshall finished his rotation, and the Saturday before he finished his rotation, he copied the 100 endoscopy reports on a copier machine and then left and moved 1,900 kilometers away to his next rotation. So his next rotation, he began the process of analyzing the data and discovered that there was some significant findings here. And so he presented his data in 1982 to the local College of Physicians in Australia. It was met with mixed review. There was a lot of skepticism from the community there. He then learned shortly after this presentation that he wouldn't move on as a resident or registrar. He didn't get the next year's position. So he had to move hospitals to Fremantle Hospital, which is another hospital in Perth, where he then continued the work and worked on the document of the data and came up with a plan to present it at the next gastroenterology meeting that was going to be held in Perth. Unfortunately, when he submitted the abstract, it was rejected. So this is a copy of the letter that hangs in Barry Marshall's office as a reminder of that sometimes research doesn't always go the right way the first time around. So this paper was rejected from the Gastroenterological Society of Australia. There were 56 abstracts out of 67 that were submitted, and he didn't make the cut. So from this, they went on and continued to kind of work independently, both Marshall and Warren independently on the data, working on a manuscript. And then the next year, they submitted a paper to Lancet. And here is the paper as it's presented. They could not find a reviewer for the paper. Nobody believed the data. One of their colleagues in the United Kingdom was able to replicate some of the data and thus provided a letter in support for this report that was published in June of 1984. And this is the original table from the first 100 patients who were identified with H. pylori. And you see here in these individuals, those individuals who had a gastric ulcer, 77% of them were found to have bacteria. Of those who were gastric ulcers, of the patients who had duodenal ulcers, 100% of them had a bacteria present, and that had a significant p-value. You see here a pretty substantial p-value of 0.00044. And in total of all the patients who presented for an EGD, you see that those who had gastritis and duodenitis and bowel and stomach, 58% of these patients had bacteria in their stomach. So from this, there was lots of skepticism. People did not believe this, but there was beginning to be a bit of consideration that this may be a significant finding, that there was a new bacteria that had been found. And they called this bacteria originally Campylobacter before they changed the name to Helicobacter pylori. As this began to be a bit more accepted, there was this idea of we need to tell people about this problem, and so they also had to prove that the bacteria actually existed and they could be eradicated. And so Barry Marshall, without notifying anybody, had one of his colleagues do an EGD on him, take a biopsy, prove that he had no H. pylori in his stomach, and then subsequently took a very concentrated concoction of H. pylori that he had isolated, took the culture, drank it, subsequently developed a horrible pyrosis, became very ill, vomited a few times a few days later, finally told his wife what he did. She subsequently said, "You've got to do something about this." And then he took antibiotics, treated the infection, and then subsequently received another EGD, biopsied, and found multitudes of H. pylori in his stomach. Thus, he proved Koch's postulate that you identify an organism, isolate it, and then treat the organism. So he fulfilled Koch's postulates with this. They needed to report this data and see if they could get wider acceptance. And this is where the popular press became involved in this problem. Star Magazine, the bastion of scientific evidence, called and spoke to Robin Warren. And upon hearing the story, and unfortunately Warren told them about the self-experimentation by Marshall of infecting himself, Star then became the lead article for the promotion of H. pylori worldwide. Interest then became much greater with regard to the identification of this new bacteria. Procter & Gamble saw this development of this new bacteria. They had development of Bismuth as a product and saw potential for marketing this to all physicians, and they came up actually with this cartoon. This cartoon was sent to every physician in the United States. Some of you are in the room. I don't know if you remember this cartoon being sent to you, but every physician who was in practice in the early 1980s was sent this cartoon so that they were made aware of H. pylori. And so from this, we have a registry project, a rejection, a submission to Lancet, skepticism, acceptance, and then it led to accolades and legacy. And what I mean by accolades is in 2005, there was the awarding of the Nobel Prize to both Barry Marshall and Robin Warren, shown here on the right. So Barry Marshall here, Robin Warren on the right, who is the pathologist. And so you have also a historical significance of this. In 1882, Koch made his discovery of tuberculosis. 1884, he proved that it existed and could be treated. And in 1905, you have the awarding of the Nobel Prize to Koch. And so 100 years later, the awarding of the Nobel Prize to Marshall and Warren. So I wanted to just take a step off of the beaten path there just to tell you a little bit about how this bacteria was developed as a pathogen and the process by which it was determined. So who should we treat if we have a positive test? Well, the answer there is all patients with a positive test should be treated. So if you have a positive test, that individual deserves treatment. So if we look at what are the treatment strategies for these individuals with H. pylori, what you see here is the latest guidelines from the American College of Gastroenterology. And the real question here is there a penicillin allergy and is there exposure to macrolides? And this is important because that leads you down these different pathways, which I'll get to in just a moment. But I want to stop here because resistance is the key factor that is changed in the treatment for H. pylori. Because resistance for clarithromycin in a local setting really tells you what antibiotic you should choose for the patient. And when you have a resistance of greater than 15% in individual or in your cohort of patients that you have, then you may not consider using clarithromycin therapy. We've talked about the classic therapies of clarithromycin triple therapy that everybody knows, the PPI, the clarithromycin, amoxicillin, or metronidazole for 14 days, and the Bismuth Quadruple therapy for 10 to 14 days of PPI, bismuth, tetracycline, and a nitroimidazole. This is the classic therapy, but this is not sufficient for some patients, and this is where you have to have a bit of finesse here in using this algorithm, which we'll review at the end in just a minute. So clarithromycin triple therapy has a duration of 14 days. It is PPI, either a standard or double dose BID, and the clarithromycin is given BID, and the amoxicillin is given as 1 gram, or you can use metronidazole at 500 milligrams 3 times a day in these individuals. It is FDA approval for H. pylori, and this is fairly effective at approximately 70 to 86% chance of eradicating the organism. Bismuth Quadruple therapy is shown here, which is a duration of 10 to 14 days. PPI as standard dose twice a day, subsalicylate or bismuth at 300 milligrams 4 times a day, and tetracycline 4 times a day. And you can use the different variations of metronidazole in this combination of 250 milligrams 4 times a day or 500 milligrams 3 times a day to 4 times a day. If you prescribe the individual components, it is not FDA approved. Only the brand name Pylori is FDA approved. So this is a little bit of a difference here, that the combination drug is FDA approved. The individual components, if you prescribe them, are not. The difference in price is substantial, though. You can get this for about $40 to $45 at local pharmacy for generic, but the brand name is substantially more expensive. So other therapies that we can consider are concomitant therapy, and this is a duration that is 10 to 14 days. And in this case, you use a PPI at a standard dose twice a day. The clarithromycin is given twice a day, 500 milligrams, amoxicillin, and nitroimidazole, like metronidazole, twice a day. It has FDA approval, it does not have FDA approval, and you can alternate between metronidazole or tinidazole in your choice of the imidazole agent. There has also been development of sequential therapy, and let me just add this figure here that all of these therapies range in eradication between 70 to 80 to 90%, depending upon resistant factors that you locally see. I'm not necessarily going to talk about the eradication success effects as much as I'm going to tell you about that these treatments exist. Sequential therapy is a duration of 5 to 7 days of each of the antibiotics, which gives you a total of 14 days. So you would start off with a PPI standard dose plus amoxicillin 1 gram twice a day for 5 to 7 days, and then that's followed by PPI. You substitute clarithromycin for the amoxicillin, and then you add a nitroimidazole, 500 milligrams twice a day, in this case for treatment of these individuals. And this is not FDA approved. There's a hybrid therapy in which you use 7 days of therapy of each of these components, which gives you 14 days of therapy. And the idea here is to change your mechanism of action on the bacteria before, so that you overcome resistance. In a hybrid fashion, you would use a PPI standard dose plus amoxicillin 1 gram, and then you can switch to a PPI, amoxicillin, clarithromycin, and nitroimidazole, 500 milligrams twice a day. And again, this is not FDA approved. There are a few other therapies, including Levofloxacin triple therapy, which is a duration of 10 to 14 days. 14 days tends to have less resistance. PPI standard dose twice a day. Levofloxacin is given once a day, and amoxicillin is 1 gram twice a day. And again, not FDA approved. There's also a duration of levofloxacin triple in which you give the duration of the levofloxacin for 5 to 7 days, and then you switch to amoxicillin to give a total of 14 days. And then there levofloxacin sequential, where you have a duration of 5 to 7 days with a total of 14 days, where you have the PPI given as standard or double dose plus the amoxicillin twice a day, and you then switch halfway through with a levofloxacin nitroimidazole treatment regimen. And then finally there is LOAD, which is a levofloxacin therapy with a PPI given as double dose once a day, and then you can use nitazoxanide 500 milligrams twice a day, which is a therapy that is used for parasites. Brand name is Alenia there, and you could use doxycycline in this regimen, which is again not FDA approved. So if you summarize what you've just gone through the different therapies here, your first question is, do you have a penicillin allergy? If you do, then you go down the pathway on the right where you have penicillin allergy. If you have a previous macrolide exposure, then you factor that into your equation, which is shown here in the second and the fourth columns, and you use a therapy that does not use a macrolide. And what they're referring to is to macrolide exposure is anybody gotten any macrolide at any point in their lifetime. So if you have received a Z-Pak, then you should avoid clarithromycin. Okay? If you've gotten a Z-Pak or any macrolide, then you should avoid clarithromycin in your regimen for treatment for H. pylori. So what are the factors which predict those who are successful for H. pylori? Well, there are some host factors and H. pylori factors that are seen. Adherence to the medication regimen is very important, getting all of the medication in. There are some adverse events that can occur with these medications and these antibiotics. Metronidazole and alcohol do not go together, and so you must advise your patient to avoid alcohol at all costs during the treatment. Nausea can develop. Metronidazole also and the macrolide have a metallic taste, which can be intolerable for some patients. We know that if you advise the patient beforehand of these effects rather than just giving them the antibiotic and sending them on their way, they're more likely to be able to eradicate the organism. There are also some genetic factors in that individuals of Asian descent tend to have a higher chance of effectiveness of treatment because there are some polymorphisms in the metabolism of the PPI, which results in higher doses and thus leads to more effective treatment of these individuals. And we see that individuals who are diabetic or smokers have a higher chance of treatment failure than those individuals who are normal blood glucose or non-smokers. H. pylori factors are also present, and these are the antibiotic things that we talk about, sensitivity and resistance to the treatment with antibiotics. And what we see is that sometimes you can overcome some of these resistance factors, which such things as high-dose metronidazole. So you can increase that dose of metronidazole if you have somebody who is potentially resistant. So what do we see the overall resistance for H. pylori? This is unpublished data from the University of Michigan, but they saw over a 5-year period of time, looking at their percent of patients, that there was not much variation in development of antibiotic resistance, but they have about a 20 to 22% chance of not being able to eradicate the organism. And if you look at other studies that have identified potential data for telling us what the resistance rate is, it's somewhere around 20% for metronidazole, clarithromycin sits around 16%, levofloxacin around 31%, and then you see much lower rates for these other drugs. So how can you look at H. pylori resistance and when should you use this testing? So you can identify resistance patterns in PCR by looking at point mutations in the 23 ribosomal subunit RNA, particularly looking at clarithromycin resistance, and levofloxacin has a 1 or 2 point mutations with DNA gyrase subunit A. Some people, the other thing is for looking at H. pylori gastric cultures. So if you have somebody who has H. pylori, they've been infected, you've treated them, You then check the bacteria again. They're positive again. You can retreat them as an attempt to overcome some of that resistance by choosing a different regimen. And then most people would say on the third time that you would consider that patient for H. pylori culture testing. We talked about the logistics in getting those cultures done. How about substituting doxycycline for tetracycline? So some people have problems finding tetracycline. It has shortage problems in the U.S., particularly in the last several years, but a recent reply to an editorial more definitively suggested from the Toronto Helicobacter Conference advises against substitution because they found that their doxycycline was inferior. And there are no randomized trials looking at a substitution of doxycycline for tetracycline. So in the case of trying to come up with a regimen, if you can't get tetracycline, it would be acceptable to use doxycycline, but you would prefer to use tetracycline in these situations. So should I test for eradication once I've treated the organism? For the most part, people would say that yes, you should. It does prevent some issue of adherence in trying to find these patients to evaluate them for H. pylori. It should be done at least 4 weeks after treatment. Those individuals should be off of PPI for at least 2 weeks in H2 blockers. And your method of testing in that case is a urea breath test or a stool antigen test to look at these individuals. In some cases, that's impractical. So if you have a patient that lives 3 or 4 hours away, it may be difficult for them to travel back. Those are the individuals that it's difficult to justify bringing them all the way back to testing. In my opinion, the best way to do this is to set up the H. pylori test for that individual at the time that you write the antibiotics for them for treatment of their H. pylori, and that's what I do in the office. So I write the antibiotics, and then I remind them in the 8 to 10 weeks, you need to come back and get your testing for H. pylori, and that's the way that I have picked up individuals who are ineffectively treated. It's not that I have a higher rate of inability to treat H. pylori, but because I've created this system where I have almost every patient come back, I've been able to pick up the people who have resistance, and then that leads me to work on their treatment regimens on the next go-round. So if you have an individual who is resistant to H. pylori, what do I do? Well, we have some guidance here. There are some therapies that are been utilized for individuals who are resistant. There's Bismuth Quadruple therapy for 14 days, again, not FDA approved. You could consider Levofloxacin triple therapy and Concomitant therapy, which we described. And then there are a couple of newer regimens that have been proposed, one of which is a rifabutin triple therapy. This is a regimen using PPI standard dose, amoxicillin, and rifabutin. And then there's a regimen called high-dose dual therapy, which is 14 days. And this uses a PPI at standard to double dose. And amoxicillin is given either as 1 gram TID or 750 milligrams QID. And we just used this yesterday or the day before as a primary therapy, not because we thought there was resistance, but an individual came to us and was found to have H. pylori, and the day before he was put on amoxicillin for an ear infection. And so we came up with, and he also had allergy to clarithromycin. So we decided to go with a high-dose dual regimen, treat 2 bugs, one antibiotic, and treat his ear infection and his H. pylori at the same time. So if you have somebody who has a persistent H. pylori infection, if you look at these individuals, if you have received clarithromycin therapy in the past, then you go down the pathway of if there was a usage of quinolone in the past or not. If there was quinolone usage in the past, then you go down this pathway of Bismuth Quadruple or rifabutin triple or high-dose dual. In those individuals who had a penicillin allergy and had received clarithromycin, you're essentially going down the pathway of a Bismuth Quadruple therapy. If an individual, however, had received Bismuth Quadruple therapy, then you go down the pathway of was there exposure to quinolone? If there was, then you're in concomitant rifabutin triple therapy territory versus going with a levofloxacin or quinolone-based treatment regimen. So, should I consider penicillin allergy testing for H. pylori eradication? And we see that 5 to 10% of the population has an allergy to penicillin, but about 90% of these people with an, quote, allergy to penicillin will have a negative skin testing and can tolerate penicillin. So it should be considered an option, but most of these people will respond to treatment with a penicillin-based therapy and won't have a reaction. So I want to end with just a few minutes left to go over a case scenario to help you kind of work through this algorithm of what we would treat that patient. So we have a 54-year-old lady who presents with a problem of coronary artery disease. She's been placed on a statin, Brilinta, and is on baby aspirin daily. She has no abdominal pain. She also takes Protonix daily for reflux. She has no allergies to any medicine, and she had a history of chlamydia 24 years ago, and she remembers taking a one-time pill, only one pill. So, should testing occur? Yes. And what's the reason why? Low-dose aspirin. So, if the answer is yes, then what direction should you go for testing? So yes, so you could choose either stool or you could choose urea breath testing. This is not somebody that you would send for an EGD. Another reason why you wouldn't necessarily jump in and do a EGD is this lady's on Brilinta, and you may have to hold that for an endoscopic procedure, although for a biopsy you wouldn't necessarily need that. But if you were planning on other things, other endoscopic indications, that we should hold the Brilinta sometimes. So we've tested the lady, and she's found to be positive for H. pylori on stool testing. And should she be treated? Yes. So which regimen are we going to select here? So here's your table. Is she penicillin allergic? No. Did she receive a macrolide? Yes. So she had chlamydia and she got a one-time pill. The only regimen I know that has a one-time only pill is giving a patient erythromycin 1 gram one-time dose for chlamydia. And so based on that, you go down this pathway of no allergy, previous macrolide exposure. So your options there are a Bismuth Quadruple, Levofloxacin Triple, Levofloxacin Sequential, or one of these other options here. So we choose a Bismuth Quadruple therapy for this patient, and we've treated the patient. So should we confirm her H. pylori eradication? Yes. Yes. And so our choices there are urea breath testing or stool testing. So basically what I've done in this last few minutes is gone through an example of a patient that would present with H. pylori and the way that you would work through the treatment for H. pylori in these patients. One of the comments that I've made recently, and we've kind of discussed this, is actually the treatment for H. pylori has become a bit more complicated than actual treatment for hepatitis C, because the regimen for hepatitis C is becoming more narrowed and more focused, and less of trying to choose the proper regimen, and whereas H. pylori has become much more complicated. So with that, I'm going to stop, and if there are any questions, I'll be glad to entertain them. Thank you. Yes?
The point of the patient that lives far away,
yes.
Can that patient mail a stool sample to you for the antigen test?
Yes, they could. Theoretically, yes. Or they could get it tested locally. I guess get your results back to you. The problem that we see is that sometimes people have an aversion to collecting stool. It's much easier to collect blood than it is to try and get somebody to submit stool for you.
So which test are you using?
So, the stool antigen.
So how do you test it?
So we send them home with the top hat collection, and they submit the stool to the lab. Yes.
How long does it take for you to confirm the patient is clear about how to take the medicine? If they can get it, if they live far away at their pharmacy, and send them home with the medicine.
So that's a struggle. Because here's the typical ad. So here's the tip. So here's the typical scenario that we have for H. pylori is they come in for the EGD, they get their biopsy, they go home, they're doing fine, and then 3 or 4 days later you realize the H. pylori is positive. Now what are you going to do? Do you bring them back in for a clinic visit to just say you need to take antibiotics? You call them and tell them. So what we have been doing is in one of our offices we kind of have a protocol where the nurse calls them and goes through what they need to do. Here I tend to call them myself and spend a little bit of time talking through the treatment and what the regimens are and side effects and so forth. But you just can't write the prescription and send them on their way, particularly in some of these complicated regimens. You really got to educate them on what they're doing. The good thing, though, is if you spend that time, they tend to take the regimen and take it to completion. Yes?
Could you share your experience with treating H. pylori in the HIV population? I specifically ask this because of the major drug interactions and it takes away 2 classes of our HIV meds.
So I have some experience, but that experience is from 10 years ago, where a population that had more H. pylori. It's difficult, and you have to work through the algorithm and find something that doesn't interact. I would probably suggest high-dose dual for the interactions there because you're only using a PPI and amoxicillin in that case, and I don't know of any interactions there, but with all the macrolide, there's definitely interaction there, and statin usage. That's the other thing that you run into, is statin usage with the macrolide.
So do these drug interactions play a major role in you picking your choice for H. pylori therapy? Like in terms of, obviously the first line we can't use in most of the HIV patient population, so it would really depend on the drug interactions.
Yeah. So yes, I'm weighing those as I find patients with H. pylori. And I've even called the physician and said, look, letting you know we've got H. pylori, and they're on HIV drugs. What do you want us to do in this situation? Here are our interactions, and then work from there. So. Yes? Okay, thank you.